Okay, so here we go with our musculoskeletal system. The section does start with several pages of your table of contents, good pictures to put notes in on, hands and feet. Just like with the anesthesia section, you will find once we get through these first few sections of codes, the musculoskeletal system flows from the top of the body, so the head or neck, and then flows all the way to the feet. So that kind of helps you get in your head how the system flows. Here are some guideline definitions of a closed treatment, open treatment, and percutaneous treatment. Good guideline here that if your code description for your big dog procedure includes external fixation, you don't code it extra. That would be unbundling, which is a huge no-no. Here are 4 kinds of excisions. Now remember, in the integumentary system, we had excisions, benign and malignant, that included a simple closure. These excisions include a simple and intermediate, because remember, these are deeper. Integumentary was just skin deep. These codes get into soft tissue, which is sub-Q, gets into muscle, the fascia, the baggie around the muscle, really can get pretty deep. So they're probably going to have to be closed in layers, and that's why they're bundled in. Starting with our first codes, wound exploration codes here. These are used if a patient comes in ER and say they have a gunshot wound or a stabbing, and the physician has to make the hole, the traumatic hole made by the gun, by the bullet, or by the blade of the knife. If the ED doc has to make it bigger in order to explore the wound, take the bullet out, whatever it is, this is when you would use these codes. Notice that they're separate procedure codes. So if the ED doc had to make the wound bigger and then realize, nope, this guy's got to go to surgery. Look, that bullet's sitting right on top of his aorta, whatever it is. Then you would not code this, and you would just code the big dog surgery. That's kind of how you do those separate procedures. Then you have a section here of excisions. These are muscle excisions, any muscle in the body, whether it's percutaneous needle, bone biopsies, that kind of stuff. I don't know what I just said. Did I say muscle excision? I meant muscle biopsy. I don't know why I put that. So then we have an introduction section. Remember, your introduction sections have all kinds of catch-all stuff in them. So there's usually a lot of injections, and this one does have quite a few of injections. It also has arthrocentesis in it. Arthro meaning joint, centesis draining fluid off. So this is where, say you have fluid on your elbow, fluid on your knee, fluid on your hip, fluid on your ankle, whatever it is, and they're going to drain the fluid off. This is where you would find those codes, either for a small joint, intermediate joint, or a major joint. And then it tells you what is small. Fingers, toes are small. Elbows, shoulders. Is there shoulder in there? I may just lied. Elbows and ankles, and then your shoulders, hips, and knees are major. So I did lie. Shoulders are in your major. Always read your parentheses, and because they will certainly help you use your codes correct. Another thing you may want to underline is code 20661. This is application of a halo. I put beside here that this particular halo, just a generic halo, is going to have 4 prongs. We do have a code here that has 6 or more prongs. So a regular halo, or if they do not tell you how many prongs, assume it's just the regular halo with 4 prongs. Here's another example of their pictures. They just kind of stick these pictures in, but yet you have more codes underneath it. So really pay attention to that. I honestly, maybe it's just me, but I have missed codes because of the pictures. Pictures are good, don't get me wrong, but I've missed them. So a lot of this is putting on those external fixators, that kind of stuff that's in here. Not too much with replantation. This is putting arms and legs back on, fingers, that kind of stuff. You don't see that very often, but that is what this section is. Then we get into grafts and implants. This section we use quite a bit if we're doing back surgeries. This is where you get your bone harvesting. Your 20900 is a bone graft, donor area. And it's divided either by a small, minor or small area, or a major or large bone donation. Cartilage grafts, fascia grafts, tendon grafts, tissue grafts. This is not skin grafts. Much, much deeper. Then you have your allografts and your autografts used for your spinal fusions, that kind of, or joint fusions. So code 20930, allograft, morcellized. You can also see this as cancellous, C-A-N-C-E-L-L-O-U-S, but morcellized, what I think of this is the Keebler elves, and they're sitting in their little treehouse, and they're talking about the little morsels of chocolate that go in their chocolate chip cookies. Everything for me is either Grey's Anatomy or food. That's just, I mean, isn't that all life is right there? Grey's Anatomy and food. I'm kidding. So morcellized are little bits of bone. They would not be supporting huge structures. They would be filling in like a filler. Your 20931 is your structural. These are cortical, C-O-R-T-I-C-A-L, or structural. These are the bigger parts of bone that may actually, in a fusion, start carrying the weight of the upper body on them. Again, these are allograft. Then you have autografts for spine surgery only, morcellized and structural. So really underline in here, once we get into our spinal fusions and stuff, we will be using these. So really make sure that you've underlined what you need to underline, so that when you come back to this code and see it in 2 months, you remember why you did what you did with it. Okay, that's all kind of the introductory stuff. Now we get into the top of the body. Remember I told you we'd start at the top of the head or the top of the body? We've got the head. Now, these different sections that I'm going to go through just are very consistent throughout the entire rest of, or most of the rest of the musculoskeletal system. They have incisions under your body part. They have excisions under your body part. One note I put in here, and it's probably because I couldn't find the code to save my life. If you have an excision of a foreign body that's removed from a muscle, that's actually probably around code 20520. That's why you see that note. Don't know that that's pertinent to you, but like I said, every time I'm in here, this is to this very day, every time I'm in here and I have trouble finding something or I needed clarification, I write my note in so I don't have to spend my time doing it a second time. So under our head, and if you want, you can even like pull out, highlight, there's our body part. We have incision, we have excision, all of these. We have manipulation. This is specific to the TMJ, but that is on the head. We have head prosthesis, so different prosthesis that might be needed whether they're ears, eyes, parts of the face, whatever. There are people that had their noses removed that have prosthetic noses. So that's in here. You have your introduction. Remember, that's the weird catch-all stuff. So if you're looking for a strange injection, probably is going to be either an introduction or other procedures. Then we have our repair, revision, reconstruction section. Now remember, these blue sections, well, not head, but these blue sections will be consistent under every body part. Genoplasty is for your chin, just in case someone's having a new chin put in. Then in here you have your Lefort 1, Lefort 2, Lefort 3. These are reconstructions of the eye orbit and surrounding parts, even into the forehead, into the cheeks. But I underline Lefort because I see that in my notes. So then I'm like, hey, I've seen that somewhere. So I go to my body part, I go to my surgery, my actual surgery repair or reconstruction, and then there they are already underlined. And then you have other procedures. Then you have your fracture and dislocation section. Now remember, this is for your head. So fracture and dislocation, and if you look, and I cannot stress to you how important it is when you're first looking at this to get a system or a process that helps you get through this page of codes or any page of codes. You've got 3 kinds of treatment. We learned that on the very first page of our musculoskeletal right here: closed, open, percutaneous. Those are the 3 kinds of treatment that you have for all fractures and dislocation. So here you have closed, closed, open, open, closed, open, percutaneous, open, open. You see what I'm doing? I'm going down. And then and then you may even want to, so this is nasal, 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 nasal. So this is an open nasal, closed nasal, open nasoethmoid, percutaneous nasoethmoid, open frontal sinus, open frontal sinus. This is a depressed and that's a complicated. But do you see what I'm doing? I'm familiar enough now that I don't need to go in and do all of this, but I really think it's to your advantage to go in when you're getting familiar with your book. Next year's book, you may not need to do this too, but this year's book, it might really help you find the right codes. So if I were you, that it not only gets you reading codes, but it gets you looking like, oh, that was nasoethmoid. This is nasoethmoid. I wonder what's different. Well, it's an open treatment and a percutaneous treatment. You see? So it helps you cultivate a good habit in critically reading these without really having to be a critical reader, because I personally am not that critical reader. My friends would tell you that. But I do well coding. Okay, so that's your fractures. Now we're into a different body system. So now we're neck, soft tissues, thorax. Again, we start with our incisions. Remember, we did that with the head. Excisions. Remember, all excisions in musculoskeletal include the simple and intermediate closures. Then we have our repair, revision, reconstruction, and then we have our fracture and dislocation of the neck and thorax. So there aren't too many here. So we have an open treatment of the ribs. Depending on how many ribs, we have a closed treatment of the sternum. We have an open treatment of the sternum. Your actual neck, cervical, is going to be under the spine. Okay, then we have other procedures, which is a catch-all. Now we're into another body part. So we have back and flank, excision. Our excision includes simple and intermediate closures. You guys will totally know that soon. Now we're into the spine. We kind of deviate a little bit because there's several weird kind of codes for the spine. different actions of procedures on the spine. So we'll get back to these body parts in just a minute. So let's do the spine here. The guidelines are really good in telling you that you need to go pick up that bone graft that we've already talked about. Tells you down here that you're going to need to code for instrumentation. I have kind of tried to collect all of the, and they have some examples on how to code stuff, which is really, really good too. But I have kind of tried to combine some of these guidelines into remembering bone grafts and remembering instrumentation. And we'll cover that in just a minute when we get to the arthrodesis or the fusions. So, okay, so we're under, what's our body part? We're under spine. So we have incisions in the spine, excisions in the spine, osteotomy, osteo meaning bone, otomy cutting into, so these are incisions into the bone. You see how that medical terminology helped? All those prefixes and suffixes. This area most of the time has to do with some spinal deformities, whether they were congenital or happened from a fall or something like that. Okay. Then we have fractures and dislocations of the spine. So again, I would go in here, closed treatment, vertebral body, closed treatment. Do you see what I'm saying? This is a fracture and or dislocation requiring casting or bracing. So go through there and so sorry. Determine your treatment, whether it's open, closed, or percutaneous, and then determine your body part. Manipulation of the spine. This is different vertebroplasties or augmentations. And then we get into the arthrodesis. This is probably the most used area of this part of the spine codes. Now, when I said I had tried to kind of combine the best or the different things to remember when you're, just a minute, I'm going to click on that, okay? When you are going to start coding for an arthrodesis or a fusion, arthro meaning joint, desis meaning fixation. So arthrodesis is a fixation of a joint. Typically, that is a fusion. So there are 5 things that you need to determine in order to either pick the right codes or to have all the codes that you need. The first is to know your approach. So I have all 5 written here. I'm going to go through them one at a time, so we're going to flip back and forth quite a bit because I want to explain to you what each of them mean. Number 1 is your approach. What I mean by that is, do you see here this says lateral, this says anterior, and this says posterior. So that's your approach. Did the surgeon approach from the front, which is anterior? Did they flip the patient over so they're laying on their belly and they approach from the posterior, back side? Or did they approach from the side, lateral, going in from the side? Okay, so that's what approach means. You can have 3 kinds. Lateral from the side, anterior means the patient's laying on their back and they go in from the front, or posterior, the patient's laying on their belly and they're going in from the back. Second, was the nervous system used? Did you have to go to the nervous system to remove a disc, something like that? We will get to that more in the nervous system, but go on and write it down now and then we'll come back to it. In the process of this arthrodesis, did they have to perform a bone graft? If they did, then we already know. We've already labeled our bone grafts back over here. Remember? Our bone grafts. You could even put the page number where they are if you want. Okay, then all you have to determine is, are they allograft, autograft, were they morselized, small bits, or were they structural? Number 4, did they use instrumentation in the arthrodesis? Instrumentation. Now I'm going to flip a couple of pages And I want you to see, starting on page 125, spinal instrumentation. You can find it two ways, segmental or non-segmental. So this is putting in rods, this is putting in cages, screws, plates, that kind of stuff. Here is a picture of a non-segmental spine instrumentation. So they've put it in and they've hooked it, it's a rod, and they've hooked it at either end. One segment bolted on. If I turn the page, you will see a segmental, this is on page 126, picture of a segmental. So there's lots of different segments with a distal hooks, intermediate hooks, and proximal hooks. Okay? So now back to page 121. Number 4 was instrumentation. So now you can put that page, where to go, segmental, non-segmental, all of that. And then the very last thing, did the physician perform evoked potentials on the patient? And up here on page 122 is where I write these down, evoked potentials, and it's code 95925 to 95927, depending on the surgery and how they may have done them. What evoked potentials is, say the patient came in and was having pain, nerve pain in their legs because they needed their back fused. So they performed a lumbar fusion on their back. Everything was done. They have instrumentation in. They've got their bone grafts in. They're ready to sew them up. They have performed the entire fusion. They then go and try to evoke the same kind of nerve pain or nerve responses that they got before the surgery. Or they try to, they test the nerves to see if the problems going into surgery have been resolved now post-surgery. So that's evoked potentials. So the 5 things again, number 1 is approach. Number 2, did you have to go to the nervous system to pick up any codes, which we have not covered yet? 3, did they do a bone graft? 4, instrumentation, that's that segmental and non-segmental. And then 5, did the physician perform evoked potentials, either on the upper body or lower body? And that kind of got us through all of this. Lots of codes, lots of pictures, but now we kind of can at least organize it in our minds. If the fusion was done posterior, then I'm not going to look at anterior or lateral. I'm just not even going to mess with it. I'm just going to go here. Gosh, at least that narrows the playing field. If it was done anterior approach, then this is the only place I'm going. So then when you get into these codes, pretty much what you're doing, you are having to read specifically what might be included in it, but you're finding your level. Was it done on the cervical spine, thoracic spine, or lumbar spine, or lumbosacral spine? However, whatever your choices are. So that's how you get through this. There's a little section thrown in here for your spine deformities. This is your scoliosis, which is the curvature of your spine, your humpback, kyphosis, those types of things, if those deformities are being fixed. Then you had your spinal instrumentation, all of this stuff telling you, the green stuff's telling you how you can combine one code with another code. If you just heard that, that's my husband leaving on a motorcycle. Holy cow, he's loud. Okay, look at code 22856. 22856. This is a total disc arthroplasty, arthro meaning joint. So this is an artificial disc being put in, and you can do it different approaches, but all of this in here is your artificial discs being put in. The little note that I put, and there's probably a lot more nowadays that I just don't see these particular op reports that often, but one brand name of artificial disc that's used is called Kineflex, K-I-N-E Flex C. So I just put that there, and so that way I have a note. I kind of know that I've been here before. So if I'm reading an op report and it has to do with artificial discs, this is where I'm going to go. Now we're out of spines and we're back into the abdomen, back into body parts, which is great. Abdomen doesn't have too much here because remember when we learned in E&M, your abdomen is kind of a body area. It's not an organ system. So there's just not a heck of a lot that you can do just with an abdomen. If you have problems with your liver, we have a liver in here. If you have problems with your appendix, we have an appendix. If you know. So this particular section, abdomen, is only about 6 codes, and it's mostly dealing with taking out a tumor in the abdomen that may just be like connected to the abdominal wall, or, you know, I don't think it would be floating around, but, you know, something, a soft tissue that's in the tissues, maybe the fat of the abdomen, that's where you would find those codes. And again, excisions in the musculoskeletal system include simple and intermediate closures. Okay, so we had the head, then the neck, then the chest, then the spine, abdomen. Now we're kind of back up to the top of the body. We've done all the trunk now. So we're going to go into the shoulder. And now we're going to get very, very consistent with these areas. We have incisions all within that shoulder. Excisions all within that shoulder. Introduction, remember a lot of different injections might be in here. Repair, revision, reconstruction of the shoulder, and then our fracture and dislocation. And as we look, we have closed treatment, clavicular fracture. Clavicle, that's the collarbone, with or without manipulation. Then we have open treatment of the clavicle fracture. We have closed treatment of the sternoclavicular dislocation. We have open treatment. So you see how you can go through and pretty much look closed, open, closed, open, closed, open, closed, open. Oops. Open, closed, open. Wonder where percutaneous is. Nope, there isn't even one. Yay for that. Okay, so if I were you, while you're getting used to this, go on, underline your types of treatment, open, closed, percutaneous, and then your body part. Manipulation, this would be manipulation of that shoulder joint under anesthesia. Arthrodesis, remember that would be a fusion of the shoulder. That would not be good to have. Amputations, and then we're into another body part. Humerus, this includes, and underneath here it tells you, once we get to the knees and hips, you kind of have to read to see what's actually included. So this includes all of the elbow area, the head and neck of the radius, and the olecranon process. Olecranon process is this part of your elbow that you hit, and it's the funny bone, but you laugh, but it really hurts. Okay, so humerus, incision, excision, introduction. Remember, weird stuff in here, injections, that kind of thing. Repair, revision, reconstruction, still of those body parts. And then we're into fractures. Closed fracture, open fracture, treatment of humeral shaft fracture. This is talking about putting in an intramedullary implant. Closed treatment, percutaneous skeletal treatment, open treatment, closed, percutaneous, open, closed, open. You see how they just flow? So go in here, underline your forms of treatment, then underline your specific body part, whether it's the radius, whether it's the radius and ulna. Is it the distal end, which is closer to the hand? Is it the proximal end, which is closer to the elbow? What is it? Now we're into forearm and wrist. if you're looking for carpal tunnel, because that has to do with tendon sheaths and nerves, you will actually find your carpal tunnel in the nervous system. I've come here looking for carpal tunnel years and years ago, so I made myself a note, and I just keep the note in because there's enough of us that either don't get in here routinely for carpal tunnel releases or newbies, you know, so I keep that in there. So here's our incisions. Excisions, introduction, again, weird stuff. Repair, revision, reconstruction. A lot of your plasties will be in here because plasty means surgical repair. Then you have your fractures of that body part. Closed, open, closed, open, open, closed, open, closed, open, closed. Percutaneous. So go in here. Here you're going to have to find, since it's forearm, is it just distal radius and ulna, or is it going to be, I think the distal end may be here, whereas the proximal end of the radius and ulna were under the elbow. Arthrodesis, if they're having to fuse the wrist. Amputations, sadly, I hope nobody has that. And then we're into a different body part, hands and fingers. Incision. See how it's very, very routine, very consistent. Excisions, repair. And lots of repairs. Into fractures. And here, this is your metacarpals, closed fracture. Make sure that you're getting your metacarpals different from your carpometacarpals. Okay, really watch your words in here, your medical terms. Then we're done with the hands. We had finished the trunk. Now we're going to go into the pelvis and the hip. So this particular section includes the head of the femur and the neck of the femur. So this is where all of your hip fractures will be, because your hip fractures generally are fractures of that top part of the femur. So you have your incisions, your excisions. Introduction, any injections are in there. Your repair, revision, reconstructions. Code 27130 is your total hip. If somebody was completely having their hip replaced, that's the code they would use. Then we get into our fracture and dislocations. Closed fracture, closed, open. Again, really make sure that you are differentiating between the minute differences in the body parts here. Open, closed, go through there. Manipulation, arthrodesis, or a fusion of that hip joint. And then here's the femur and knee joint. Okay, this is going to be the thigh region of the femur, not that head and neck. So incision, excision, introduction, repair, revision, reconstruction. Your code 27447 is your total knee arthroplasty. So that's your total knee if your knee's been replaced. Then your fractures, closed, open, percutaneous. Again, really watch your distal ends, your proximal ends. Those, you've got to know those terms in order to accurately pick your codes. Into the tibia, fibula, and ankle. Incision, excision, introduction, not much here, thank goodness, yay. Repair, revision, reconstruction. Then your fractures. So here again, you're going to have to differentiate between the tibia and the fibula, the shaft of the tibia or fibula, the proximal end, which is toward the head, the distal end, which is toward the feet. And then the foot and toes. That's the last part of the body parts. Same kind of thing here. You get to your fractures. Oh, you do have, they've added this. You've got some great pictures of bunionectomies and how they fix some of them. They kind of changed. They don't use Keller anymore, I don't think. They use Kirschner wires. They use McBride and Mayo techniques, but these are good pictures in here. Pretty good. They didn't used to have that, even more. So there obviously was a lot of problem coding these correct, in my opinion, or we wouldn't have so many pictures in here. They were tough to code too. And then your fractures and dislocations, closed, open, percutaneous. Okay, so that ends all of the body parts. Okay, so now we're getting into another section. One thing I would like to say before we move into the applications, cast and strappings. We have talked about the open treatment, closed treatment, and percutaneous treatment of a fracture or dislocation. When we get to diagnosing, you have open fractures and you have closed fractures. Do not confuse the treatment type to the diagnosing of the fracture type. You could have an open treatment for a closed fracture or a closed treatment to an open fracture. And we'll talk about this again when we go to get in our ICD-10 and go through the diagnosing. I just wanted to throw that out there so you can kind of get familiar with how confusing it is. Just because something was treated open or closed does not mean that the fracture, that does not drive the type of fracture it is. That's all I'm saying. Okay, application of casts and strappings. We have, if you can see my book, I've got lots and lots and lots of underlined stuff because this is where they like to really screw you up. Cast and strappings. If a patient shows up to the emergency room and has a broken wrist, and the physician, the ED physician goes in, manipulates the fracture, realigns it, and puts a cast on, that cast is bundled into the treatment of that fracture. Okay? If there is definitive treatment of the fracture or dislocation at the time of treatment, and a cast or strapping is put on at that time of definitive treatment, you do not code from here. Boom, don't do it. Let me say that again. If at the time of definitive treatment of the fracture or dislocation, a cast, splint, strap, immobilizer, whatever you want to call it, was put on at the time of definitive treatment, you do not code from here. That's what this is telling you up here. Don't do it. If I come in with that broken wrist and the ED doc looks and says, yeah, I think you need to see an orthopedist. Here, I'm just going to kind of straighten it a little and stick it and immobilize it, and you go see the orthopedist tomorrow. He didn't fix my fracture. He just immobilized it for pain control and to stabilize it somewhat till I could get definitive treatment from the orthopedist. Now, the ED doc gets to code for that cast and strapping. Okay? So if my fractured, don't you love my fractured wrist? If my fractured wrist was not definitively, that means it was straightened, manipulated, surgery, whatever, at the time of treatment, if it was not definitively fixed, if it was just splinted because it was so swollen, they couldn't do anything till the swelling goes down. You know, you hear stuff like that. Or I'm having to go see the orthopedist tomorrow or this afternoon or whenever. And the ED doc immobilized it until I could get definitive treatment. Now that's when we get to code from here. So one of the ways is the initial without definitive treatment. That's when we can code here. So I put in here at the initial time that the fracture is being looked at, but there was no definitive treatment, I can code from here. The only other time I can code from here is if it's a replacement. So I'm in the ED, I have this broken wrist, they straighten it, they cast it, and I go home and take a shower. and I don't put my Walmart bag or don't put my saran wrap on it, and that plaster cast gets all limpy, wet, sticky, and everything. So I have to go back to the emergency room to get a new one put on. Now they can code for that too, because it's a replacement. It's not going to be the same cast that was put on at the definitive time of treatment. And that's what all of this underlying stuff in here is telling you. Okay? And then your casts and strappings are divided by body parts. And that's it. The very last part of the musculoskeletal system is your endoscopy and arthroscopy section. This section involves all the body parts. So endoscopy, your scopes are not a part of any of the body parts previously. They're all put in under one section. So you'll see we start, our first code starts with that TMJ joint. And then we have our shoulder, and this is exactly what I would expect you to do, is go through here just like I'm doing. Like here's a rotator cuff repair, very, very common repair. So those were all shoulders. Now we're into elbows. We're into wrist. You see what I'm doing? I'm pulling out. So my eyes see all those body parts. Hip. Now you'll see some of these, like your 29830 is an elbow diagnostic. Your 29834 is an elbow surgical. So if you're doing a scope, say my elbow is just killing me. I come in, my elbow's just killing me. So they decided to scope it and try to see what's wrong. They go in there, didn't find anything wrong. That's a diagnostic scope. They were trying to diagnose something and couldn't. There was nothing wrong. Same scenario, my elbow really hurts. They go in as a diagnostic scope, and then they find out I have a splintered bone, or I have a bone spur or something, and that's what's causing my pain. Now it just became surgical when they go and fix what's wrong. So you wouldn't code the diagnostic, you would code the surgical. Okay, so that's the difference. So you'll see, sorry, you'll see in here diagnostic and surgical, and that's the difference with lots of different body parts. So go through here. Your knees, I think, all start 29866. That's probably the most worked on, is the knee. Couple of notes to put with the knees. Let's look at code 29874. This is a scope, removal of loose body or foreign bodies floating around in there. A lot of times your docs call that plica, P-L-I-C-A. So I just have beside there plica removal. Just kind of helps my eyes pick that up. You can kind of stack these depending on what the docs do while they're in there. 29879, 29879. This is where the doc does some drilling of P-I-C-K holes. Just thought I'd throw that in there. And one key thing that I underline in here, or it'll bite you, I'm telling you, 29880, that's a meniscectomy, medial and lateral. So here's the knee, and you have medial and lateral ligaments that get screwed up like very easily. That's the majority of knee injuries, are their meniscus, whether it's the medial, the inside side, or the lateral, the outside side. So this meniscectomy, ectomy meaning removal. So they have removed part or all of the meniscus from the medial side and the lateral side. So then the next code, 29881, with meniscectomy, medial or lateral. Do you see how that one word made a heck of a big difference? 29882, meniscus repair, medial or lateral. 29883, meniscus repair, medial and lateral. Okay, please underline those as you encounter any description in here that has that kind of differentiation, I'm telling you, it will be a time saver for you to go on and take the time to critically start differentiating between them now. Okay, and that is it for musculoskeletal. And we go right into respiratory. Bet you thought you were going to get your rest, but you do not. The respiratory isn't that awful bad, I promise. It's not too many pages. Again, you have your table of contents here and a great page for notes and to look at different excuse me, body parts. So here's the respiratory system. Like the musculoskeletal and like anesthesia, it starts at the top of the body where the air comes in. So our air comes in our nose. Yes, we are mouth breathers, but our feet breathers. The mouth is in the digestive system because it is the first part of the digestive system. We take in food in our mouth. We don't take food into our nose. So technically nose is the first place, if we shut our mouth, it's the first place that we take in air. So here is an incision section for the nose, excision. You will get in here, I promise you, and we'll probably do some underlining. You can see I've underlined 3 places that were trouble for me. Under repair is where you find your rhinoplasties, septal repairs, septoplasties, I believe are over here. Yep, septoplasties 30520. All of that kind of stuff is in that surgical repair section. Destruction, this would be ablation. Ablation's a great word for destruction of different soft tissue issues within the turbinates. You have other procedures in here. This is control of nosebleeds with packing and that kind of stuff. Ligating arteries because they bleed. Maybe from high blood pressure, that kind of stuff. Then we're into accessory sinuses. We have a lot of sinuses. We have sinuses above our eyebrows. We have sinuses straight behind our eyes and behind our nose. We have sinuses kind of in our cheek, maxillary sinuses. So we have ethmoid sinuses, sphenoid sinuses, and maxillary sinuses. So in here, under sinuses, we have incision codes here, and I want you to make a note from code 31020 to 31040. These codes include the scope. So if you're trying to code for any of these and their way of doing or performing the procedure was by way of a scope, these codes include it. You would not code extra for a scope. Okay. Then we get into this endoscopy section, and just like with the backs, I have kind of made a 1 through 5 question for yourself to catch all the codes, to anticipate all the different scenarios so that you're coding completely. Always code to the fullest extent. So if they went all the way into the ethmoid sinuses, make sure you're accounting for that, that type of thing. So what are some questions you need to ask yourself? Number 1, what are the sinuses involved? So as you look through these different codes, you can see maxillary, sphenoid, ethmoid will be over here in a minute. Ethmoid over here. So determine when you're reading your op report what different sinuses are involved here. Then, was anything removed? Did they do an ethmoidectomy? Take some of the sinuses out? Did they take out polyps? Did they remove anything? And if so, what was it? Was it a partial or a complete? Number 4, did they perform an antrostomy? Ostomy, remember that's a surgical creation of an opening, like a colostomy. They're surgically creating an opening into the colon where there wasn't one. an opening. Tracheostomy, they are creating an opening into the trachea where there wasn't one. So they're artificially creating an opening. And antrostomy is they're artificially creating an opening, but it's kind of like when you walk into a antrum of a big, like an embassy suites. Everybody think about an embassy suites. You walk in, you check in, and then there's a ceiling above you and blah, 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 blah. And then you walk over to the elevators and you look up and you can see all the way up to the top, all 8 or 10 floors. And it's just an open area. That's what an antrostomy is. They are surgically creating an open area so that the sinuses can breathe, so that they have room, so that they're not as crowded, and then they will function better. So that's kind of what an antrostomy is. And then 5, where their polyps removed. So as we kind of look through here, knowing these 5 things we've gone through, we can kind of pick stuff out. Like 31237, that's a biopsy, surgical, that could have involved taking out a polyp, a polypectomy, ectomy removal, polyp. Okay. Now, a really good sheet in here. I don't do great with these endoscopies, the sinus endoscopies. They seem really hard to me, and it's hard to pick out the information and that kind of stuff in the scenarios. We'll walk through all that stuff, but it's not the easiest coding. What helps me the most are these parentheses right here. If you look, they are different combinations of some of the most common endoscopic procedures that they do on the sinuses. And I find more of my collection of codes here for the endoscopies than trying to piece them together myself. Same thing up underneath these. Okay, so really maybe even, you know, kind of show yourself, remind yourself that you're going to want to go look at all of these and these too, because they might really, once you get to frontal sinus exploration, surgical, you know you're in the right place, but you're just having trouble finding the right combination. I would imagine if you read some of these, you'll find it, and it will at least help you streamline into the right code. Okay, then out of the accessory sinuses, we go to the larynx. We have excision codes. We have your 31500s, the universal intubation code. If someone can't breathe on their own and they're going to have to be endotracheal or breathe through their trachea, they're going to do an endotracheal intubation. This is also where your tracheostomy tube change might be for different issues. Okay, then you have scopes, laryngoscopy, laryngoscopy. I'll say that right in a minute. I said it like some of my friends say it. Laryngoscopy here. So these are the scopes involving the larynx. Repair codes. So these, all the suffixes, most of them will be plasty because that's surgical repair. Then you're into your trachea, incision codes. So these are your tracheostomies, whether it's emergency or planned. Then starting with code 31622, let's look at this. 31622, underline it. That is your bronchoscopies. So they're putting a scope down into the bronchi and looking for stuff, taking biopsies, cleaning stuff. Who knows what they're doing? So all of these, write a little note that you can, what I call stack these. You can stack these. You can put them one on top of each other if they were done. So let's say that they performed a bronchial lavage and they took a biopsy. Now remember, all of these are indented. So they include the description to the semicolon. So bronchoscopy, rigid or flexible, including fluoroscopic guidance when performed, semicolon. So we said they did a lavage. So here's your bronchial alveolar lavage. And then I said they did a bronchial biopsy. So here's bronchial biopsy. So you can code both 31624 and 31625 together. Now, how would you stack those? I personally, since a biopsy involves removing something from the body to go be tested, I would do the biopsy first, and then I would put a 59 modifier on that lavage. Some payers, you might have to just do a 51 as a multiple procedure. I'd probably try it as a 59, but I might get it denied. Okay, so you can stack these. That's an example of stacking them. And if you look, all of these, all the way down are your bronchoscopies. And kind of what I do is I make arrows. See, I still got bronchoscopies coming down here. Still got bronchoscopies all the way over here. So here's my bronchoscopy way over here. And I still have them coming all the way. Still got them. I got them all the way to 31654. All the way. So this just kind of helps you organize this area so that when you get to here and you're looking at bronchoscopies, you know you've got all these codes to search through to find the right one. I kind of don't like how I did that. Okay? So that kind of helps you. At least divide it up. We do the same thing with our colonoscopies, sigmoidoscopies, and that kind of stuff. Okay, so now we're into our lungs and pleura. Pleura is the baggie around the heart, around the lungs, sorry. Incision. These are actually incisions into the chest cavity, not into the lung. Pneumonostomy. This is creating a surgical opening. Excision, resection of the lung. Code 32320, decortication. That means removing the surface layer. Just anytime you have a term in here that you don't know, I would recommend you look it up, write the definition, or have a spiral notebook that you keep kind of a running vocabulary, medical term vocabulary. Once you read it, look it up, and write it down and use it a couple of times, it's going to be familiar enough. This biopsy, 32400, this pleura biopsy, I do want you to write in here that it can include aspiration of tissue or blood. Okay, can include aspiration of tissue and blood. And then we have a removal of the lung, different parts thereof. You must know, let's go back to this very first page. You must know which side has 3 lobes, which side has 2 lobes. Okay? So go back in your medical terminology textbook, do some labeling. You need to know which side has 3 lobes, which side has 2 lobes. That affects potentially how you pick a code. When you are, like if they're doing a pneumonectomy, ectomy means removal, pneumo lung. That doesn't mean they're removing all 5 lobes of both the lungs and the patient has no more lungs. That would be a transplant. I mean, you can't live without all of your lungs. So really pay attention to lobes, whether it's 1 lobe, 2 lobes, segment of a lobe. You see what I'm saying? Really kind of here, review your anatomy so that you can accurately apply these terms. Code 32551 is a chest tube. You've seen in Grey's Anatomy, patients, their chest is filling up with blood. So then they get their little hemostats out and get on the side of the ribs. They fill the ribs, they make an incision, and then they stick in their hemostats. And they put a tube in, and all of a sudden all this blood comes out. That's a chest tube. Absolutely one of my favorite times. I just love it when they put chest tubes in. I think I could do it myself, is how many times I've seen that stuff, which is frightening to the patient that I might be playing on. But anyway, that's what it is, just a little bit of humor. So again, this is your introduction section. Has all different kinds of weird stuff in here. Here's your thoracentesis. This is the drawing off of fluid in the chest cavity. Or, yeah. Your VATS. Lots of codes for VATS. Stereotactic radiation therapy. Stereotactic generally means radioactive. This is really, really highly specialized stuff in here. Your lung transplants. We just do not see many of these codes at all. I don't spend a lot of time talking about from VATS on. You may have to come to VATS and look up a code. It's just video assisted surgery. That's all it is. It sounds like some big heinous something, but it isn't. They're just using some type of video to assist with the surgery. So a lot of the stuff you see in here is still just common stuff, but it's they're just using a scope, VATS, that kind of stuff. I don't know that you will encounter your lung transplantation codes on the test. If you do, you only have a few to choose from, but that's where they are. So that is respiratory therapy. I mean, respiratory and musculoskeletal all combined. So see, we're already to the hearts. Now, you'll be very happy to know you're doing cardiovascular. You only have one chapter the entire week because it's such a big, kind of difficult area. So we're going to cut you some slack. So, okay, so very good. We are good. And the next organ system will be cardio.